introduce Dr. Selvig. Dr. Selvig attended medical school at the University of Michigan and then came to UCSF for residency and fellowship. He has been an assistant professor at UCSF since 2020 and has become a GI functional disorder whisperer. I'm always amazed during my clinical session with Dr. Selvig at how much tool he has in his disposal when caring for these challenging patients. He handled them with such grace and ease that it sometimes tempted me to centralize functional disorder myself until I go into inpatient and I have someone who chronically and it just slap me back to reality. And like, I'm not there. So I'm super excited that he's going to talk about how to approach functional GI disorder. This talk is incredibly high yield and I have referenced multiple times during the last 2 years. So I would recommend a first year fellow, it's time to get out your laptop and just start typing down Dan's pearls of wisdom. And here you go, Dan.
Okay, well, thank you, Mike. Very kind of you. I am here. Let me share my screen. All right. Can people see my slides? All right. Well, as Maya said, I'm going to be giving my talk entitled Approach to Functional Gastrointestinal Disorders. I'm happy to be giving this talk in part because these are so common. Probably close to half of the people you'll see in an outpatient gastrointestinal clinic are going to have a functional gastrointestinal disorder. So this does encompass a huge portion of our field. I do not have any disclosures. Starting off, I want to talk about our terminology here. So what are functional gastrointestinal disorders? The more current or perhaps more popular terminology now is going to be disorders of gut-brain interaction, or DGBIs. So in fact, I probably should have entitled this talk Approach to Disorders of Gut-Brain Interaction. The idea is that that term likely captures some of the pathophysiology that's going on here in terms of the communication between the gut and the brain better than the word functional gastrointestinal disorders, which just implies sort of a change in function of the organ itself. But regardless, you'll probably hear both of these terms used to describe this type of disorder. Irritable bowel syndrome is the classic example of a functional gastrointestinal disorder, but there are many others. And these are different than other medical conditions that we see because they are defined not by objective measurable findings like biomarkers like a blood test or an ulcer or inflammation seen on colonoscopy. Instead, the functional gastrointestinal disorders are defined by what the patient tells you and what they feel. So it's a collection of symptoms, behaviors, pains, things like that. The underlying or root cause of these disorders is often multifactorial. So there can be underlying biological causes, there can be psychological contributors, even social elements can play a role. So they can be a little complicated to know why one person has a functional gastrointestinal disorder and another person doesn't. All right. The Rome Foundation is perhaps the definitive group that makes our definitions about these types of disorders. And when I counted from their Rome 4 Foundation publications, I think there were 33 different functional gastrointestinal disorders. So you can just start at the top of the digestive tract and go all the way down. And pretty much anywhere that you can have chronic, bothersome digestive symptoms, there will be a defined functional disorder. So globus, starting up in the throat, all the way down to functional anorectal pain disorders down in the rectum and everywhere in between. The most common that you're going to see, and so the ones I'm going to talk about most in this talk are number one, irritable bowel syndrome, which I think is our prototype functional gastrointestinal disorder, and then also functional dyspepsia, which is a little more in the upper abdomen as opposed to irritable bowel syndrome, which is a little more in the lower abdomen and the bowels. Irritable bowel syndrome, the things that we're looking for in diagnosing it and defining it are recurrent abdominal pain or discomfort, It's happening with some frequency and it's chronic. So it's been present for at least the last 3 months, and it started at least 6 months ago. The other things you're looking for is that it's related to defecation or bowel movements. You're seeing some change in the frequency of the stool or change in the form or appearance of stool, so looser stools or harder stools. Some things to remember of what is not irritable bowel syndrome. If you have bowel habit changes, but no pain, discomfort, urgency. For example, if you just have watery diarrhea, but it's completely painless, there's no cramping, pain, or anything with it, then you might be dealing with something like a chronic idiopathic diarrhea rather than technically irritable bowel syndrome. Similarly, if you're just having pain, like a chronic pain in the abdomen, but there's nothing related to the bowel habits at all, that also wouldn't quite be irritable bowel syndrome. It might be a different functional disorder. So you're really looking for discomfort or cramping or bloating, pain, and also these change in the bowel movements to define someone with irritable bowel syndrome. So you're going to hear this when you talk to the patient. They're going to report these things. And you're going to start thinking, this sounds a lot like irritable bowel syndrome. Let's see. In your interview with the patient, you're going to be getting those factors, that history, and then you're going to be thinking about whether this patient has any red flags. So signs or symptoms that there might be something worrisome or dangerous going on that it's going to need some more investigation. You're going to ask about blood in the stool, black or tarry stool, unintended weight loss or difficulty maintaining their weight, and age of onset at a later age. People can get irritable bowel syndrome at any age, but if you start to get new symptoms, in midlife, it warrants thinking about something else. I've actually moved my personal practice. I've probably moved this age of onset over 50 to be a little younger. I mean, now we're doing screening colonoscopies, for example, people who are 45 or younger. So now if I'm seeing people in their 40s with new onset symptoms, I might be even a little more inclined to do some further investigation. People with a strong family history, either of colon cancer or inflammatory bowel disease, you may do more workup than usual. If the symptoms are progressive, so if they start as typical irritable bowel syndrome, but they're becoming worse and worse and worse, where now the patient can't work and things are just clearly going the wrong direction or becoming life-alteringly severe, you might do additional workup. And then the finding of nocturnal diarrhea, so being awoken at night multiple times to rush to the bathroom, is a little less typical of irritable bowel syndrome. So in those cases, I'd say more workup is required, and that often is going to include a colonoscopy with or without an upper endoscopy, depending on the patient's symptoms. Now, if they don't have those red flags and you're dealing with chronic, stable duration of symptoms, you usually don't have to do too much testing before you can be pretty confident that someone has irritable bowel syndrome if they have typical onset and typical symptoms. The few tests that you do want to remember to do, and this is for patients with irritable bowel syndrome tending towards the diarrhea side of the spectrum, you do want to check for celiac disease. So that'd be a tissue transglutaminase plus a total IgA. You want to do a stool test to look make sure you're not missing inflammatory bowel disease. So here we're commonly using fecal calprotectin. Using a CRP, if you're not in a place where you can easily get the stool test, could be acceptable. And then fecal lactoferrin is sometimes used, although I like the test characteristics of the calprotectin a little better. And then you can consider a chronic infection with Giardia if the patient has some risk factors. So if they're exposed to sort of unprocessed water, like hikers, untreated water, or people who are exposed to contact with human feces, so having diaper-aged children, things like this. Once in a while, we'll find a Giardia infection and treat it, and somebody will feel somewhat better. So you can consider that if there are some risk factors. So once you've gone through, a history of a patient who sounds like they have irritable bowel syndrome, you've ruled out some red flags, potentially ordered a couple tests. I think that the most important thing in how your patient's going to do with the irritable bowel syndrome is what you say to them and how you talk to them about IBS. I think this is probably more important than what medications you choose, what diet the patient does, is how they understand their condition. It plays a huge role in what their course is going to be like. So I'm going to start. I have some do's and do nots listed here. So starting with the what you should do and what I'd like you to do, give the patient a positive diagnosis. That is, tell them that they have IBS. And I would say do this at the first visit. So if you've done your history, you're thinking IBS because they match the symptom criteria. You're going to do some additional testing. You're going to order your tissue transglutaminase. You're going to get your calprotectin. Don't wait until those labs come back at the next visit to say, okay, now it's irritable bowel syndrome, because they might not have a follow-up visit for you, or it might go a long time, or they're going to go a long time without thinking that you don't know what it is. So I think in that first visit, even if you're going to get some additional testing, I spend the majority of my time talking about irritable bowel syndrome. Even if, yeah, again, if that other testing comes back positive, we change the strategy. But I think you should talk a lot about irritable bowel syndrome in that first visit. I usually start the discussion by saying, what you're telling me sounds like irritable bowel syndrome. And then I ask them in a very open-ended way, what have they read about irritable bowel syndrome, or what have people told them about that word irritable bowel syndrome? Have they heard of it? Almost everyone will have heard of the term irritable bowel syndrome, and people will have a wildly different, thoughts about what that means. You'll have people who say, "Oh, I think it's something to do with your diet," or you'll have people who find that to be a stigmatized term. So they'll say, "Well, it just means the doctor kind of gives up and doesn't really know what's going on." So I want to ask them what they've heard about it, what people have told them about it, so that you can start the conversation from there. So, for example, if they're saying if the patient says, "Well, it just means they can't find anything wrong," then you can start from there and say, "Well, there's some element to that, in that it's a condition where the lab tests and findings, aren't the key to it." But then you can ask them, "Well, can I tell you how we think about it?" And then you can give your spiel, your talk about irritable bowel syndrome. So this brings me to the sort of the point number 3 on the you should side, and I would say educate the patient about irritable bowel syndrome. So I spend a decent amount of time giving my little speech about irritable bowel syndrome, if that's what I think we have. So I tell people a few things about it. I tell them there's some good things and there's some bad things. So good things that we know about irritable bowel syndrome: it doesn't kill people. It doesn't shorten your life. You live just as long with it as without it. It doesn't seem to, cause irreparable organ damage. It does not seem to lead to cancers. These are all good things. On the bad things we don't like, is that it can cause a lot of misery and daily symptoms. It can be long-term and can come and go in severity. And we don't usually have a one-time fix that's just going to make it go away forever. It's often a deal of finding some strategies and patterns that can work to help when it flares up and help people manage it on their own. So there are some good things and some bad things from the patient's perspective to irritable bowel syndrome. I do talk a little bit about where irritable bowel syndrome might come from and why this patient in front of me might have it and some might not. We know that for some people, their irritable bowel syndrome is due to something specific that happened to them in the past. The example of this that I think is the most revealing is the post-infectious irritable bowel syndrome. So somebody could have totally normal bowel habits, no problems at all, and they get a really bad infection, E. coli or food poisoning or something like this, and afterwards the intestines can be, never the same again, and they could have IBS. So this is a well-known phenomenon, post-infectious irritable bowel syndrome. So I bring up this idea to the patients and say it's possible that there's something in your past that triggered some change in the function here. I usually do even talk a little bit about some details of physiology here. So I say that, for example, when there's an infection, there will be white blood cells going to the colon lining to heal up the infection. These white blood cells will trigger some chemical changes with interleukins and cytokines and things like this that are causing some changes in the function and the nerve program of the area. And then you're left with irritable bowel syndrome, which leads to changes in the function, changes in the sensation, and these bothersome symptoms that can last a long time. I think that mentioning this post-infection irritable bowel syndrome when you're telling someone about the diagnosis helps to show that this is it helps to not trivialize the diagnosis, that this is a real thing, that they're not to be blamed for their diagnosis. It's not a condition that's purely in your mind. And so I do think that talking about some of the physiology about how it can start as a post-infectious phenomenon can help people to understand, believe it, and not feel stigmatized about the diagnosis. I will, depending on how much time I have, I will actually talk about a couple of the more specific nervous system changes that can happen with this. So I'll bring up the term visceral hypersensitivity. So visceral hypersensitivity, meaning the internal organs feel pain at a lower threshold than they used to. So I might say that, before you had irritable bowel syndrome, you might have bubbles of gas passing through the intestine, or chunks of undigested food passing through the intestine, or bacterial changes. And the nerves of the intestine wouldn't have even sent signals to the brain about it, or they wouldn't have reached a level of being aware of them. But after you have irritable bowel syndrome, those same things might happen. A bubble of gas can pass through a chunk of undigested food, and you get repeated signals of pain and alarm coming from the intestines with the exact same thing happening. And we can call that visceral hypersensitivity. The other word that I'll bring up to patients is autonomic dysfunction. This is the body's balance between the rest and digest program and the fight or flight program. So I'll tell patients how it's easy to get stuck into a loop where the autonomic system can make things worse and spiral. So for example, if you feel pain or you're afraid that you're about to feel pain, well, that can trigger the fight or flight response. The fight or flight response then has a powerful effect on the physiology of the digestion. So the blood will rush away from the digestive organs, the movement patterns will change, and this can often make the pain worse. And so I show patients how the changes in the fight or flight axis can lead to the symptoms lasting longer and being worse than they otherwise would be. So a lot of my first visit in a patient who I suspect has IBS is talking about a lot of these things. I think it helps to destigmatize the disease, that we do know a lot of the physiology of it, even if there aren't objective lab findings for any one specific patient. And it gives them a framework for how to think about it. So they're not afraid of it being an undiagnosed cancer. Rather, they can feel a little bit more empowered to try different self-management techniques to see about managing the symptoms. And then when I talk about the beginnings to the approach of how we treat irritable bowel syndrome, I usually group it into three main categories because different patients will have a instinct for which they think will work best for them. So the three major things I think would be dietary approaches, behavioral or psychological type approaches, stress reduction, mindfulness, cognitive behavioral therapy, things like this, or medications and supplements, of which there are many. Some patients, and I bring it out like that in a big menu, some patients will say, oh, I know it's kind of dietary for me, I don't like taking medications, and then we can make our plan more focused on different dietary approaches. Or some people will say, oh, I've tried all the diets, it's just a pain, and so do you have a pill that can really help me feel better? And then we talk about more of the medicines. So just kind of laying out the broad range of types of treatments, the patient will often have an idea of which things they'd like to try first. That'll help guide you. So I don't have a specific, you must do this first, this second, this third with an IBS patient, because it's going to depend on their symptoms and the types of treatment approach that they're likely to want to fit into their life. A couple things here on the right about what not to do with irritable bowel syndrome. You don't want to give them the impression that they're a medical mystery because the labs haven't shown anything. So if you see them for this first visit, they meet all the criteria for IBS, you think they have IBS, but you decide, well, I'll wait for the labs to come back and tell them later. Then at the next visit, maybe they postpone it or come 6 months later. And so they've gone all this time thinking that you're a medical mystery. They have no idea what they have. And so they're looking it up on the internet. So you just want to avoid the spiral of repeated testing that's negative to where the patient doesn't know what they have. And then you don't want to trivialize the diagnosis either. I don't think we want to say like, oh, it's just IBS, or oh, good news, it's not a dangerous diagnosis, because it can be a fairly life-altering thing. People miss a lot of work for it. It can really be a huge factor in people's lives. So you don't want to say just IBS. You want to treat it, seriously and talk to them honestly about it. So again, how you talk about it and getting some time to say these things to the patient is probably the most important thing in starting the patient out on the right foot of getting better from IBS. All right. A few of the specific management things you can do for IBS, and there are a ton. It's going to vary based on whether they're diarrhea predominant symptoms, the constipation predominant symptoms, or the mixed type symptoms. So I put a list of some of the options here. It's not an exhaustive list. There's a bunch more. I'm going to go, there's a few of these ones that I have put a slide on here that I'm going to go over in a minute to talk about some details of a few specific ones of these. While I'm here on this slide, I'm going to mention a couple other things. So us as gastroenterologists, I think we should be quite familiar with some of the prescription ones, like the new FDA-approved prescription medications. The patient will often do some of these over-the-counter things on their own, or the primary care doctor can do a lot of the over-the-counter things, or some of the simpler or more tried and true prescriptions. But I think we owe it to have at least the options of doing some of the prescription ones. So for example, for the diarrhea predominant IBS, we are the ones who kind of own access to like eloxatiline for very severe cases, or elocitron for very severe cases. We should be experts in the use of these non-absorbable antibiotics, rifaximin, some of the other prescription ones. And for the constipation predominant ones, some primary care doctors will prescribe some of the prescription ones, like a linaclotide, but often it'll take getting to a gastroenterologist before they're able to try some of these prescription constipation predominant medications like the linaclotide, plecanatide, lubiprostone, tenapanor. So we owe it to ourselves to be familiar with these for the patients who are kind of refractory to primary care management. I don't have a lot of detailed slides on these in each one, but I think we should all be familiar with these. Getting into a little detail on some of the very commonly used things that come up a lot in clinic. I want to start with the low FODMAP diet. A lot of patients and a lot of primary care doctors will already have been familiar with this, but this is one of the most studied dietary interventions for irritable bowel syndrome symptoms. I think we should use it, but you should be aware of a few things that can go wrong or things to be careful of with it. So low FODMAP diet, what it is it's a diet that tries to reduce, it's an acronym. So if you're trying to reduce these fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, the idea is that you're reducing some of these chemicals that are digested by the bacteria into gases and excess fluids. But it's important to remember this is not a forever diet. It's a very restrictive diet. So it's not one where you just say, oh, do the low FODMAP diet, and that's all you say, because then a year later, the patient's still going to be trying to do their best to stick on the low FODMAP diet, and it's just not even a nutritionally complete diet. It's far too restrictive and complete. So it's kind of a program. You do a phase where you restrict for a couple of weeks, then you reintroduce some foods gradually and try to get back to the broadest diet that you can for nutrition purposes, while limiting and learning some things about what have been your triggers. And then for chronic treatment, then you sort of individualize and have a few things that you limit or adjust, but mostly you want to have the broadest healthy diet that you can. Yeah, so some tips. Don't do the full restriction, phase one forever. It's not how it's supposed to work. It's just too restrictive. Number two would be There are some patients who I don't even bother to talk about dietary restrictions if I'm already worried that the patient is a little too restrictive with their diet. There is a condition called avoidant restrictive food intake disorder, or ARFID. This is, how I think this works is that somebody will feel bloating, cramping, diarrhea shortly after eating blueberries, let's say, and then they say, okay, I'm never eating blueberries again. And then, the next day they eat, toast, and then they say, I'm never eating bread again. And through a gradual process, they just keep cutting out foods until they come to you and have a list of foods that they do eat. And they say, all I eat is broccoli, chicken, and quinoa, or something like this, because everything else has caused me bloating. So I've cut it out in the past. This is too much. This is not how we want people to go. It can also be kind of a trap, because once you convince yourself that blueberries are the problem, and if you try blueberries again, simply the fear of exposing yourself to something that you think is going to cause digestive distress can trigger a fight or flight response and be a self-fulfilling prophecy. So people can kind of get stuck in this. So if somebody comes to me with a list of the foods that they do eat, I'm definitely not trying to get them to restrict things. I'm trying to get them to gradually add back things. So if I get the hint that people have really been too overexcited about dietary restrictions to the point where they're not getting good nutrition, I try to steer them in the opposite direction. If you are going to use the low FODMAP diet, it's helpful to have a dietitian or a nutritionist if you can, because it is a little complicated, and they're going to be cutting out a tremendous amount of foods that are going to be in their diet. So that can be very helpful. For people who don't prefer that or don't have access to nutrition, you do want to make sure they get really good education and information about it. The Monash University website I've found to be a very good one. That's the University of Australia that did some of the work in developing the diet. So they have really good info. So don't be afraid to use the low FODMAP diet, but there are some tips to it. All right, antispasmodics. These are another really commonly used one, but there are some tricks and pitfalls. So the ones you'll most commonly see or perhaps use here in the United States will be dicyclamine or Bentyl, and then hyoscyamine, Levsin. These are pretty good. So they just cause a few hours of the intestines not to spasm. So people who have post-meal spasming discomfort, these can be a good option to take shortly before the meal, for example. I do watch out for these because they're anticholinergic is the main way that they work. And so I think that they're not a good choice for people over 65 because the side effects can be worse. You do want to warn, these are medicines you can use on an as-needed basis, so they don't have to be taken every day. A lot of patients don't want to be taking an everyday medication, so this can be something they can keep in their pocket or a cabinet in case they're having a bad day. It can be useful. Watch out for things like dizziness, dry mouth, little blurry vision, drowsiness, or constipation. Again, anticholinergic side effects. But again, be careful with patients with comorbidities, urinary retention, older patients you want to watch out for. Peppermint oil is a useful one to use as sort of a first line if people are interested in supplements and want to avoid side effects. The theory here is that peppermint oil does promote smooth muscle relaxation of the digestive muscles. There have been some studies showing some effect with this. Not all of them, but some have shown some effect. Similar to an antispasmodic, like I mentioned in the last slide, you might use these 30 minutes before a meal to stop some of that spasming and cramping and rush to the bathroom that can happen after meals in a lot of patients. One nuance to watch for with peppermint oil supplements is because they have a muscle relaxing effect, they can relax the lower esophageal sphincter if they're in the stomach, which can lead to a little heartburn. So there are encapsulated formulations. IV Guard is probably the most well-known brand name here, that are designed to release a little lower down to give some of the benefit without that heartburn side effect. All right. Rifaximin, the minimally absorbed antibiotic, can be useful. It is FDA approved for irritable bowel syndrome with diarrhea. And the idea here is that some of these people might have small intestinal bacterial overgrowth, overlying things, or regardless of the population of bacteria or how much, whether they actually have diagnosed SIBO, they might be sensitive to changes in bacterial populations or even minor overgrowths here. So rifaximin can get people out of a flare of their irritable bowel syndrome in a lot of cases. The dose here is 550 milligrams 3 times a day, often for 2 weeks. Side effects here pretty darn rare. It can be very costly. So if it's not covered by insurance or they have a very high copay, you might look for an alternative antibiotic. And then it can be helpful to sort of risk stratify which patients have some objective evidence of bacterial overgrowth by using a breath test to see if there's some objective evidence of small intestinal bacterial overgrowth to sort of stratify who's most likely to respond to rifaximin. If you have a good enough story for small intestinal bacterial overgrowth in a patient with IBS, I think a lot of us will still use it if the patient doesn't want to go through with a breath test or doesn't have access to it. So I think there is some practice variation in terms of the use of breath tests for it, but rifaximin can be helpful and can get a lot of people out of a bad flare-up of their IBS symptoms. All right, tricyclic antidepressants, or TCAs. These can be helpful, especially with the pain symptoms of irritable bowel syndrome. These have been shown to help with the sort of global overall symptoms of irritable bowel syndrome in research studies. There are 2 types of these TCA that you're going to want to be familiar with. So I kind of put them in boxes here at the bottom of the slide. There's the tertiary amine TCAs, by which we're meaning amitriptyline and imipramine. The tertiary amine TCAs are different in that they have a little bit more of the anticholinergic side effects, so a little bit more constipating. These would be a good one to try if you have irritable bowel syndrome with diarrhea. The secondary amine tricyclic antidepressants, so desipramine, nortriptyline, a little bit less of the anticholinergic side effects. So you might try this if you were using a tricyclic antidepressant in someone with mixed or tending towards the constipation side of things. But you will, if you're using it for a patient with IBS with constipation, you will want to watch out for worsening the constipation, since the anticholinergic side effect will tend towards that. I think that we should feel comfortable prescribing these for irritable bowel syndrome. You do want to start real low, because side effects when they start taking it are fairly common. You might see this pattern where when you first start taking the antidepressant, there's a little bit of side effects, drowsiness, things like this, but they can tend to decrease a little bit with time as you become accustomed to the medication. Then you can gradually increase the dose. So what we see is that the side effects tend to happen at the beginning and get a little better with time, but the benefit of taking the antidepressants often takes several weeks or longer to ramp up. So you kind of warn people about this. So they don't just take one pill, say, I kind of felt a little off, and then abandon it. Right. There are some psychological therapies that can help in irritable bowel syndrome. So cognitive behavioral therapy and gut-directed hypnotherapy are a couple that have shown some benefit in irritable bowel syndrome. If you have access to a counselor, a psychologist who can do the cognitive behavioral therapy, that would probably be the ideal. Although, there just aren't enough of those people in the country to see everybody who has irritable bowel syndrome. For people who don't have access to that, you can have them watch videos about it or read books about it to kind of get an idea, some of these ideas of the psychological underpinnings of IBS. There's even, so the ACG has a website called GI On Demand that I've been having some people go to. The patient can put in their email address, get a free account, and then you can watch some pretty good educational videos that give some of the philosophies on the psychological therapies in IBS and the roots of chronic pain in IBS. So that can be an option if you can't always get a patient in front of a counselor. And then there's some apps to help and guide people through cognitive behavioral therapy or sort of gut-directed mindfulness, hypnosis. So Nerva is one that at least has a 1-week free trial that you'll have people try sometimes. There's a couple of these other ones, so Zemedy or Mahana IBS. At least one of these you can do as a prescription, and then they get a code sent to them to get the app. There can be some limitations with cost. They're often not free or have ongoing costs, which I think has probably limited some of their big uptake. But I think these will be, I think we're only going to see the growth of these as they become more popular. All right. So that's what I wanted to say about IBS. I have some to say now about functional dyspepsia. So as opposed to irritable bowel syndrome, which is these chronic digestive discomforts linked to the bowel habits, functional dyspepsia is more chronic recurrent symptoms in the upper digestive area. So very often related to food intake, but you're getting things like feeling really full after meals, getting full early during a meal, having pain in the upper abdomen, or like burning sensation in the upper abdomen. Again, like all the functional gastrointestinal disorders, it's something that's been chronic, so something that happened for more than 6 months. And then it's also defined by not having an obvious structural cause. So if somebody has an ulcer or pancreatitis or something like this, that's an alternative diagnosis, then that would be that and not functional dyspepsia. There are these two subtypes of functional dyspepsia that it's worth remembering because the treatment can be a little bit different. So in the group of functional dyspepsia, there is postprandial distress syndrome, and there is epigastric pain syndrome. So in the postprandial distress syndrome, it's more these immediately after meal symptoms of feeling full, of feeling bloated, like that. The epigastric pain syndrome is maybe more of a burning sensation and might or might not be related to meals quite as directly. So it might actually get, be when they're hungry and get better with meals, or just be less related to meal intake. There are some other symptoms of functional dyspepsia, so belching, bloating, nausea can kind of overlap with all these. And I'll talk a little bit more about some approaches to belching and bloating in a couple minutes. But so there can certainly be some overlap between these two. This is just a chart with a little bit of an overview of the workup and some initial management of dyspepsia symptoms. So this is from the ACG and Canadian guidelines from 2017, this chart. So an adult dyspepsia patient with these symptoms comes to your clinic. First, you want to find out, is there a reason to do an upper endoscopy? Not everyone with these symptoms, because they're so common, needs an upper endoscopy. So in these ACG and Canadian guidelines, they would suggest that if somebody has a new onset over 60 years of age, you'd go right to endoscopy. But if they're not over 60 years of age, you don't necessarily need to. I think there is a little nuance to this one. So in different countries, for example, I think this age cutoff might be a little different. In countries where there's higher incidence of gastric cancer, or in people who have immigrated from countries. So if you had a patient who immigrated from South Korea and they're 50 years old and have new onset dyspepsia, I absolutely would do an upper endoscopy on them, because they have a much different risk profile of finding something organic in the stomach compared to somebody who's lived in the United States their whole life. So I think this age cutoff is a little flexible, but just the point being that you don't necessarily need to do upper endoscopy on everyone with chronic upper digestive symptoms. The other thing, other than age, you want to think about here is major red flag symptoms. So overt gastrointestinal bleeding, unintended weight loss, dysphagia. There are a lot of things that could prompt us to go down the path of endoscopy here as well. For those patients who are young and without red flag symptoms, it's often recommended to try testing for H. pylori and treating that if it's positive. If it doesn't work, you can try a trial of a proton pump inhibitor. If that's not working, you can try a tricyclic antidepressant, or they recommend a prokinetic. I think the prokinetics aren't used quite as commonly in my experience, because the ones we have access to in the United States aren't quite the same. So for example, domperidone is not available, or cisapride. And Reglan, I think, as a prokinetic, has a little bit unfavorable side effect profile. So I think we're not using these as much in my experience. And then there's, psychotherapy, or some of these approaches towards the mind-gut connection that can be used. There are also a number of sort of milder or supplement type treatments, curcumin, FD Guard is a supplement. So there's other mild things you can contrived. So this is kind of a basic overview of some of the treatment of this. And a little bit more I wanted to add on some of these neuromodulators for functional dyspepsia. So some of the medications that get at the neurotransmitters. This is where it's important to distinguish between the postprandial distress syndrome of the bloating and early fullness compared with the epigastric pain syndromes. If you're going to use a neuromodulator and somebody's got this sort of like fullness, bloating type pain, and or nausea, you might want to use buspirone or mirtazapine as your options. Whereas if it's more this burning upper abdominal pain, you might try the tricyclic antidepressant or an SNRI. And again, each of these medications has their sort of pros and cons and side effects that you should know about, but just to say that your strategy of what neuromodulator you use might be different based on what kind of functional dyspepsia they have. I have a couple more sections at the end of my talk here about belching and about bloating, because these can be happening in patients with IBS or functional dyspepsia, or their patients might show up with these as their primary complaint. So a little bit of tips and tricks on these ones. For belching, you should understand and you should be able to explain to the patient. Excuse me, I almost sneezed. You should be able to explain to the patient there's two types of belching. One is the gastric belch. This is what most people think of. There's gas sitting in the stomach for whatever reason, and then it comes up and you belch it. That's a gastric belch. Supragastric belching, that is belching coming from above the stomach. It's not coming from, the gas is not sitting in the stomach waiting to be expelled. Instead, you have the diaphragm contract down, sort of create a vacuum in the esophagus that then pulls air in from above through the pharynx and then immediately ejects it and you belch. The air in this situation comes from, through the mouth, through the pharynx into the esophagus, and then is belched out. It never gets to the stomach or comes from the stomach. That's a supragastric belch. When a patient is belching multiple times per minute, is sitting in your clinic belching and belching and belching, this is almost certainly supragastric belching. So understanding the difference between these two and being able to explain it to patients can help them understand what's going on with these belching. This was from a research study on patients with bothersome symptomatic belching. And so this is kind of, if you looked left to right on this impedance tracing here, on the left hand, we see the supragastric belching. So the deviation of this line, meaning sort of the air going into the esophagus, you can see as you go from left to right in terms of time, you start with the air coming in the top of the esophagus, moving down the bottom of the esophagus, and then moving right back up. And then with the purely gastric belch, you can see the air beginning at the bottom of the esophagus and then with time going to the top of the esophagus. So this just to show that you can, with these measuring techniques, distinguish between these two types of belching. And so researchers have looked at patients with really bothersome belching and seen, which is it? Is it gastric belches or supragastric belches? In this research study, these were patients who had gastroesophageal reflux disease along with bothersome belching compared to patients who just had a primary belching disorder. But in both of them, the vast majority of belching episodes, whether it was associated with reflux or whether it was in patients without reflux but just bothersome belching, the red here is the supragastric belching, and the blue is the gastric belching. So the vast majority of these episodes of bothersome belching are this supragastric belch, where it's the diaphragm contracting, pulling air in from above, and belching it back out, not air being created by something in the stomach and then coming back up. So the reason it's helpful to understand is because one of the best treatments for belching is diaphragmatic breathing exercises. So if a patient comes in with the bothersome belching, you can explain this phenomenon to them and then talk to them about the diaphragmatic breathing. I'm just going to go over this one study that's been done for this. It was kind of a key study to show how helpful this can be. They took patients with reflux and troublesome belching and then had them be taught by a speech therapist how to do the diaphragmatic breathing. And they compared it to patients on a wait list. And what they found, if you look at the top here, this is the patients who did the diaphragmatic breathing exercise in terms of symptom severity. You can see the vast majority of these lines are people, went down in terms of severity. They got better after they did the diaphragmatic breathing. And the people on the wait list here at the bottom, there wasn't really much of a change. So the statistic from this paper is about 60% of people had a more than 50% reduction in their belching severity, whereas none of the people on the wait list had that. So this is a very safe thing you can do to help with bothersome belching for people. If you don't have access to um, like a speech therapist to guide someone on this, that GI on demand that I mentioned earlier does have a couple videos on the benefits of diaphragmatic breathing and how to do it. So I'll give people access to that sometimes. So this can be helpful. All right. In the last few minutes, I want to talk about bloating. So bloating is a very common complaint and reason to come into a digestive disease clinic. When I'm hearing about bloating, I want to help distinguish and clarify between bloating and distension. I think the word bloating in our minds kind of has two different, or in the words of patients who come in, have a couple different things. One, they can mean the sense of a bothersome trapped gas, like there's discomfort and gases or something needs to move through. And then people will also say bloating and mean that their abdomen is visibly, physically distended, or they'll say they look like they're pregnant. Both of those things are often included when a patient says they're bloated. So it helps to ask them those couple things. There's some interesting research on this distension, this bothersome distension that can happen with people to help explain this to patients. Patients with this bloating and distended, they really do get physically distended in the abdomen, even if there's not increased intra-abdominal contents. So people will show you pictures. They'll try to prove to you how distended their abdomen gets. You can believe them because they really do get more distended because of this condition. This research study, the authors, introduced gas into the colon in patients in sort of control groups. That's the green line here, that did not have chronic bothersome bloating and distension. And then in patients who had chronic bothersome bloating and distension, the red line here, they introduced the same amount of gas. So you can see that on this top right chart, this is the patient's perception of gas being introduced into the colon. Patients with bothersome bloating, the red line, could feel the gas being inflated at lower volumes, which I think makes sense for those of us who kind of familiar with the idea of visceral hypersensitivity, probably feel intra-abdominal contents more. But this bottom right chart I thought was revealing. It's not just that they could feel it more, it's the abdomen. They're looking at the girth around the abdomen. For the same volume of gas inflated into the colon, the patients with bothersome chronic bloating and distension actually distended physically more. With the same amount of volume, their abdomen stuck out much further. So what's going on here? The idea behind this is a concept called abdominophrenic dyssynergia. When in the normal case, so somebody without bothersome chronic bloating and distension, when there's an increase in intra-abdominal contents, the body has some ways to make way for that. The diaphragm muscle will move up a little bit to make some room for it. The front of the abdomen and side of the abdomen wall can tighten a little bit to kind of maintain the body's regular shape. And that's and you don't notice anything. In people with this bothersome bloating and distension, some of the opposite things can happen. In this same study, they did EMG tracings of the diaphragm and some of the abdominal wall muscles, and you can see the patients being in red and the healthy subjects being in green. In some cases, they're moving in the opposite direction here. So instead of the diaphragm moving up to make room for the new gases and keep things overall looking the same, the diaphragm moved in the opposite direction, pushed down on the abdomen, which then caused it to stick out more in the abdominal wall muscles instead of sort of tightening to keep things in shape, relaxed to get this sort of distended look. I think this can be helpful in patients with this bothersome bloating and distension because explaining this concept to patients will help understand that people will say, like, what's in there? There's got to be something in there because it's visibly bigger. So is it gases? Is it stool? Is it some fluid buildup or something like this? Once you've evaluated it or are comfortable there's not something worrisome going on, this can help explain that it can be a muscle sort of reflex issue behind this. And even just understanding that can help people understand it's not necessarily something worrisome, undiagnosed going on to cause the distension of the abdomen. The treatment for this abdominophrenic dyssynergia that's been described is like a biofeedback where they look at the muscle tone and you learn to counteract it. I have not found that to be a very easy to access type of therapy just because of the rarity of this, people who can do that. So you can use diaphragmatic breathing for this as well to help teach a little more conscious diaphragmatic control and sort of reset the position of these organs. So that's what I'll have people do if I suspect this as a cause of distension. And then there are some other causes of bloating that you should think through. Bloating is common in irritable bowel syndrome, functional dyspepsia, and can just present on its own. So you'll want to review through with the patient and think through which contributing causes you might have. So there are dietary factors. Is there constipation that's perhaps slightly subclinical constipation, bacterial overgrowth, visceral hypersensitivity, or this abdominophrenic dyssynergia? So you can go through these possible causes with the patient, again, after you've ruled out that they have some like real ascites or something like this. There are a lot of options for bloating as well. All right. Well, I covered a lot here, and there was a lot still that I didn't cover because it's such a huge topic. But I did want to get to some of those highlights and leave just a couple minutes to see if people have questions about these things.